Cost of living increase is a key challenge to pretty much everybody. But in this episode, we're going to have a look at how that's going to affect particular aspects of healthcare, especially the NHS and general practice, what those exact challenges are for the practices themselves, and hopefully some solutions to help you understand how you can mitigate some of that and make it a little bit more manageable as we try and answer the question, can general practice survive cost of living increase? Let's take enhance your primary care and learning. Hello, EGP learners, and welcome to this episode where myself and Andy are going to be tackling this key question about can general practice actually survive the cost of living increase that's coming our way? It's an emotive topic, Andy. Hopefully, we've got lots of viewers joining us as well because I think this is going to be an interesting topic. But what are your initial thoughts of what we're going to talk about and stuff?
Yeah, I mean, it sounds bleak, doesn't it? My initial thought is general practice has thus far proven to be quite resilient, currently battered and bruised. My hope is that we'll survive. But I think the key question is how difficult is it going to be, and how are we going to survive, and how can people and their practices position themselves to be in the best position to continue to help patients through what's going to be a really, really difficult time, and make sure that they survive, don't get burnt out, and are able to perform okay and be satisfied in their jobs through it as well. It's going to be challenging, but hopefully we've got some tips towards the ends that people can put in place to help as well. But how have we got here, Gandhi? How have we got to this point where we're talking about the cost of living crisis?
Well, I think it's important we do talk about what the exact challenges are. And I think it's important that we understand some of the difficulties that are coming our way, in particular, how this is going to work and stuff. I guess the key things that many people are probably aware of, because it's dominated the news cycles for the past few months and now has impacted on the energy crisis in particular, is obviously the war in Ukraine has affected supplies in terms of energy and gas. And that's led to an increase in basically energy costs in particular. And that's one of the key ones that many of us are going to be facing in terms of the cost of wholesale gas and other parts of energy is just skyrocketed. And because of that, there are now changes to what's called the price cap for energy, which is basically Ofgem who monitors this. They basically say that this is the maximum energy companies can charge, and it's going up quickly, isn't it, Andy? And quite significantly.
Yeah, yeah. I mean, the price cap and energy costs are one part of it. I guess we've come into the situation on the back of the COVID-19 crisis, which has
Mhm.
left the government financial position in a worse state than before. There's been lots of borrowing to support the health service, support the economy, support people who weren't able to work. So public finances aren't in a great position. There is problems with supply chain that were all sort of stuck up really during the COVID
Yeah.
crisis. Goods weren't getting to where they should be. There was an increase in demand for physical goods as people wanted to buy things rather than services, and that pushed up the cost of a lot of physical goods that we would buy. Following that, people then went out, they wanted services, so lots of demand for services, but there's a reduction in the available workforce. People have left the workforce. There's been Brexit, which might
Mhm.
have had an impact on many of these things, including availability of workforce. So there's a whole myriad of factors that have been pushing up inflation, which is really the key
Yeah.
figure when we're talking about the cost of living, and that tops 10% uh, last month, which is, I believe, the highest inflation rate for about 40 years. So all this
Yep.
culminates to make life very difficult for patients that use general practice, particularly in difficult areas of high indices of multiple deprivation, and for all practices and practices in those areas. Difficult
Yeah.
times.
So if you're not sure what inflation is, basically it's the rate at which the cost of stuff goes up by. So generally speaking, inflation is always there. We would hope so, because otherwise you've got recessions if that's not happening, or deflation that leads to recessions and stuff. But being at 10%, so that the value of your money is, well, the worth of your money is going up by 10%, but unfortunately that's actually the cost of everything is also going up by 10%. And if your income doesn't, you basically end up with net loss of income. And that's the key thing, isn't it, Andy, that we're seeing for many places.
It is. And of course, the inflation is the average increase in the cost of all the goods and
Mhm.
services that people might seek to buy as they live their lives in this country. But it's not evenly spread. So some things go up more than others.
Yeah.
And so we all have what we might call our sort of personal rate of inflation, or the rate of inflation for the types of things that certain categories of people buy might be different. So if you're a poorer family and a large proportion of your household spending, household income goes to energy costs, and energy costs go up by 100%, they double, then your personal rate of inflation that you're experiencing might be much higher than the average 10% as well. So it's sort of even worse for some people than that 10%
Mhm.
implies. So those are the factors that have led to us talking about the cost of living crisis.
Mhm.
Why is this going to be difficult for general practice, Gandhi, and why are we talking about it this morning?
So I think there's a couple of things to note in terms of why, when it affects general practice. First of all, we've got a reducing workforce, so the number of people around is definitely less. But actually, the question then is, how do we balance the inflation costs with the various other things that are coming through? Important to remember in general practice, the income that general practice and practices in particular have is generally static. The reason for that, general practice works off a capitation-based model, so they get a set amount per patient per year, regardless of how many times that patient has contact with the practice. And that rate has been pretty much set for the past 3, 4 years based off the contract negotiations made in 2018, 19. And that's something the government's sticking to quite keenly. Despite all the challenges, they've repeatedly said that general practice has had a negotiated contract from about 3, 4 years ago, pre-COVID. And as a result of that, we're not making any significant increases in the funding that's available unless there's other stuff that comes with it. And we'll come to that in a second.
Absolutely. And I'm sure what some people out there will be thinking, and we'll get to later, is there is that's the core contract. There is primary care network funding, which is additional and is increasing. So we're not ignoring that. But actually,
Mhm.
when you're running a GP practice, that funding isn't directly available to you. That's a separate budget.
Yep.
So actually, in terms of GP practice finances, it's still very difficult to manage in an inflation environment of 10% when you have an annual increase of 3%,
Yeah.
to cover your costs. It's going to be difficult. Um,
And that's the
there's a
key
number
thing,
of
is that, Andy, costs are just gonna go up. This is the thing. If your income is generally static and you don't have a mechanism by increasing that income, so remember, GPs can't charge patients for access and that kind of stuff. We can't stop how many people come to us, and actually, we know that more people are gonna come to us as well. I'm gonna come to the workload implications of this shortly. But the key thing is that the costs are gonna go up, and the big costs are gonna go up as well. So we've talked about energy. I've already heard some projections from some practices where their energy bills are expected to go from something like £15,000 a year, which is relatively average cost for a business, of a reasonable size, to £90,000 a year. So that's the level they're talking about by January, because it's a variety of things that impact that. And if you are suddenly having to find, what is that, £75,000 a year extra out of your budget just for one of those costs, and we're going to come to the other ones, that's scary. That's
that
really
that is
scary.
scary. That is an insane figure. That's going to place that organisation under significant stress. I think this is a thing which, whilst there's a lot of focus on the impact on individuals, the impact on services, not just GP surgeries, but
Mhm.
schools, hospitals, other government-funded services and private businesses, for that matter, that people use and rely on, are also going to be under a lot of pressure.
Mhm.
And we'll come to the energy price cap, but that doesn't apply to businesses as well. They're the energy costs for individuals are doubling, but people are actually being protected from the full increase in the wholesale cost of energy by
Mhm.
the price cap, and it's the cap that's doubling. So businesses are exposed to even higher fluctuations in the cost of things like energy. But I guess to start to break it down, I'm just going to cough. Proof that we are live this morning.
Mhm.
Uh, I think the first thing that people may experience, will be experiencing a lot of things already, but I've been experiencing an increased level of worry, anxiety, stress from patients as they see all of this talk of the cost of living crisis and how this is already and will affect them more going forwards. So I'm beginning to see that come through. We're seeing a lot more appointments with people who are under financial stress or other stresses related to this, and that's only going to increase. That's going to be really difficult. And on top of the existing pressures and catching up, a lot of the activity that was postponed or didn't happen due to COVID was still in the process of doing that. Um, we're getting an increase in requests for letters of support for things like applications to benefit, to problems people are having with their housing. And in the winter, actually, heating issues are something that we are often contacted about to support with. So I think that
Mhm.
will be happening more as well. We've got a bit of an issue with blue badges. I think the local council have changed their policy and they want a GP letter now when they didn't. But I think as other services come under pressure and need ways to differentiate between patients based on how needy they are, a lot of them resort to outsourcing that work to GPs and ask them to get a GP letter, which I think is really, really difficult. Have you noticed an increase in these activities or letters requests, Gandhi?
I think definitely seeing an increase in particularly housing challenges for many patients. Already having some patients come to us saying that they're struggling to heat their homes, the impact that's having on respiratory conditions in particular. So mold issues because people can't afford to heat their homes effectively, then that leads to upkeep issues. And particularly when you and I both work in fairly deprived areas, unfortunately, sometimes the state of the accommodations is less of a, shall we say, standard, and that has an impact in both upkeep from the owners of the properties, whether that's council, private landlords, or other kind of things, but also the tenants themselves or the owners themselves just don't have the funds to upkeep the properties. That leads to more health issues because of the respiratory drive issues that some of them are facing, and other aspects. And safe
Yeah,
housing, overcrowding, all those kind of things are factors that we are going to see more of. People wanting to move, so letters for housing, as you mentioned. The blue badge one, yeah. It's interesting. There recently was a concordat, which I believe is like a direction, one produced by the government to basically show other organisations that using the GP as the barometer for how much people need services shouldn't really be happening anymore. That actually that indication of go to your GP to get a letter to justify that you need this service, well, it's not often appropriate, and actually that puts a huge element of trust away from the services. Again, important to remember that most practices will charge for those letters because it's not an NHS service, and that's going to be an element of conflict for many people because the increased number of people saying, "Well, I need a letter, but I can't afford a letter. You're not helping me." That's
yeah,
going to be a thing. Yeah.
Yeah, it leads to an increase in difficult conversations, doesn't it, with patients around those sorts of issues, which happen anyway, but they're going to be happening more and more.
Hmm.
Which is on to the other point. I've been learning a new phrase over the past year or maybe a few years. This term about emotional labour that people have
Hmm.
started talking about, and that's the concept that having difficult conversations, challenging conversations with people who are in a stressed and emotional state, or very unwell, which makes things emotionally charged, actually takes more of a toll on healthcare professionals than doing the same amount of work, same amount of consultations that might be technically as challenging or technically more challenging, but have a lower emotional content. And that actually that high level of emotional labor is actually very, very disproportionately draining
Yep.
and leads to an increased risk of burnout and poor performance and dissatisfaction in those jobs. So I think we're going to see a lot more emotional labor being expended, and that's going to take its toll. And that's never really costed
Mm.
or acknowledged thus far, although people are talking about it more. But that's a concern that I've got about being us as a group of healthcare professionals and the people that we work with being exposed to a higher level of emotional labor. It's going to be difficult. We've got to think
Yeah,
about how we're going to
and
cope with
and that
that.
will lead to an increased level of burnout, which we're already seeing across our profession in terms of clinicians, admin staff leaving because they just cannot take the pressures that it's currently having, and we know these pressures are gonna deepen and worsen, particularly with some of these things. Um,
Yeah.
we are likely to see an increased consultation rate as well for a variety of things. So a classic one that obviously many patients are exposed to is patients who have free prescriptions when they're asked to self-care and obtain things directly from the pharmacy. I think there's going to be an increase in number of people saying, well, no, I have free prescriptions. I want it on prescription. Then I don't have to pay for it. Which, some people feel one way on that spectrum and some people feel on another, but it's the workload that comes with that that's going to be the key challenge, I think, for general practice in particular, because we are going to see an increased number of people doing that. Because why wouldn't you, to be honest?
Absolutely. Yeah. And I guess just for people watching, we're breaking down what the problems are at the moment because I think we need an honest talk about it. We will be
Yep.
talking about some tips and get a little bit more optimistic towards the end because there are things that you can do if you identify what the problems are, what's coming down the road. There are things that
Mhm.
you can put in place when you anticipate these problems. So stick around until a little bit later when we'll be getting
And
into
for
some
those of you that are
solutions.
joining us live, thank you for the likes so far. We would love to hear your comments and your thoughts on this, so stick those down in the chat as well because we really want to know your perspectives, and we accept that we're probably going to miss some things. So definitely chip in with those as well to help us and stuff. But yeah, where we were
Yeah.
going next, Andy?
Yeah. Well, I was going to say, very keen to know what people are experiencing and what solutions they are beginning to put in place. If they have tips for other people, then we can obviously share them. So an exercise that we went through recently was putting into place some of the staff wage increases. So we do our annual increase in April, and for a lot of our staff, that meant a 3% increase. For many of them, it meant a lot more than that, actually, because a lot of our staff, unfortunately, are paid minimum wage, particularly in some of the admin and reception roles. They should get paid a lot more than that. I think they do a complicated and great job, but that's the way things are. But they received an increase in the minimum wage, which was actually quite significant, and worthy. And then we've been told that we need to increase staff wages further. The government has decided to increase staff wages further. Eligible dentists and doctors, the Doctors and Dentists Review Board advised an increase of 4.5%, and I believe that was backdated, although I might to April. I may be wrong, Gandhi. If we don't know, we'll just flag that we're not sure about that. But that's an additional cost over what was expected previously. And there were some minimum increases for the lowest paid staff. This is tracked to Agenda for Change, which applies to hospital pay scales. Not all general practices will deliver those increases because we don't need to deliver Agenda for Change increases. But actually, to remain competitive with other employees in the healthcare sector, often you have to do that. Otherwise, your wages and terms and conditions just fall so far behind. But the lowest paid clinical staff were guaranteed £1,400 increase, which means that some staff would have received a 9.3% increase, which is getting close to that inflation mark. Definitely worthy. But Gandhi, what's the challenge for practices here in terms of delivering these
so as we mentioned, GP practice income is going to remain static. That there is no planned increase for general practice income, and we've heard that very clearly from the government. So if they're saying that you need to increase your staff costs, which is often for many practices the biggest cost that they have, unless of course you're one of those practices now paying £90,000 additionally for your energy and stuff, then how can you balance those books? How can you make that effective? And many practices want to reward their staff. All of our staff across the board have been working exceptionally amazingly over the pandemic and stuff, and to support them, because obviously if you don't pay your staff, they're not going to come to work, and then you're going to have people leaving, and then that makes the pressures on the business even more so. But then if you don't have the funds to actually do that, does that mean the practice goes under? Does that mean they have to hand back the contract? Does that mean that the partners who run the practice are then paying to work, which is a reality in some places? We're going to talk about why that deepens in a few seconds. But there are going to be some significant challenges that come because of the fact that the income is static, and definitely not rising anywhere near to the line of inflation or to the expectations of what they will need to pay out and stuff. So there's challenges.
Or a reduction in services. People may have to not recruit that additional GP, that additional nurse that they may have been planning to. In some cases, people may not replace people that leave. I've not heard of people actually dismissing clinical staff, but in some dire effort to control costs, that could be possible. So actually, people may see the level of service delivered by their GPs' surgeries reduce as a result of this cost squeeze around wages and wage increases. It puts
here's the reality. If you don't have an increase in income, you only have two generally ways of managing that. You either reduce your costs, and as we mentioned, in terms of costs that you can we'll talk about a few ways that practices can do that. But one of the big ones that many practices may have to consider is staff redundancies, or you reduce your service. And I think that's the one that many people are concerned about, because we've just already talked about the fact that patient demand is going to go up because of this. So if your demand is going up even more so, but you are then having to reduce your service because you don't have the funds to make it manageable, that's not going to be great for our patients, is it, Andy?
No, it's not. And it comes at a time when people are already expressing dissatisfaction with the service at GP surgeries to a greater extent than they have done in many, many years. But the pain doesn't stop there, because for some people who may be in that position where they're closer to retirement, they've already built up some funds in their NHS pension, there is an issue related to how increases in the value of that pension are calculated that include inflation, which mean that when inflation levels are high, the imputed value of that pension might increase on an annual basis above a certain threshold, which means people have to pay additional taxes on those pension contributions. I've probably not represented that quite right, and there are some good articles out there that'll enable people to understand that fully. Gandhi might have another crack at explaining that, but it can mean effectively that people, when you tot up the pension contribution, the tax, the national insurance of what you're working, you can end up negative. You can end up actually paying
Paying to
money
work.
to
Yeah.
work. For every hour you work, you can be paying money and actually earning nothing and actually losing income, which sounds absolutely ridiculous. But that will be a situation for some GPs out there and other people working in the health service. I'm sure a lot of consultants and other people will be affected by this as well. At a time when we probably want people to work and do more hours
Yeah.
if they can to deliver more service, they're going to be very, very challenged to do that if they actually have to pay to do that. It just seems completely absurd.
So I guess, as Andy mentioned, this is a complicated area to understand, and we are not going to do it justice. So I would highly recommend that people who are concerned about this part, and that's pretty much as far as I'm being able to understand, anybody within 10 years of retirement. So that's not, you know, that's a lot more people than you probably think. If you're anywhere near 10 years towards retirement, absolutely you need to be looking at this pension issue. And the best resources we can direct you to, so there's Dr. Tony Gladstone, who does amazing work in terms of helping to navigate some of this, and there's some BMA calculators and stuff to help manage some of this stuff. But absolutely, I definitely recommend having a listen to the Medics Money podcast. Who two guys who I've worked with, declaration there. But their information on these particular issues is detailed and supportive, and they will have to, they are the best resource I can recommend, particularly for doctors, to look at this issue and understand it a bit more effectively, and absolutely have a look at your pensions and get some advice, because it's really complicated, and that's the best way to figure it out, if I'm being honest. Um, and whether you're at risk of it, and I know it's something I'm actively trying to do, and it's a long process because, let's be honest, PSC and total rewards is a bit of a nightmare. But hey,
Oh,
we're not going to talk
don't,
any more on
don't
that
get me
particular.
started. Where's
Yeah.
my total reward statement? I've been bugging you for ages to provide it. But anyway, thank you, PSC. PSC.
But there are other challenges as well. So we mentioned, obviously, that costs of things are going to go up. So this is going to affect, in particular, the supply of items. So key one for anyone involved in general practice is going to be the cost of prescriptions and the drugs themselves and the supply chains for those drugs. They're going to have a huge impact in terms of medication costs and the underlying NHS budget in terms of how things cost. And actually, the hidden cost that many people don't see, but has a huge workload implication for primary care and pharmacies and various other aspects. And that's when a drug is not available, finding an alternative for the patient. It's a massive workload implication that is not costed within the system, but actually those challenges and the health implications for those patients when you're having to switch medications. This is going to be a growing problem, because we know that the cost of the drugs are going to go up. We know that the availability of the drugs is going to go up, and the reliability of the availability of the drugs is going to go up as well, go down actually. So yeah, I think I've got that right, haven't I, Andy?
I think so. I think I've got the gist of what you're saying. I think it's going to get worse.
Yeah.
Yeah, I'm not sure if those are the words you said, but yeah, it's going to be really, yeah, it's difficult. It takes a lot of time to do those substitutions when there are supply chain issues, and that takes time away from other activities that we should be doing in practice to look after people. Yeah, I mean, the cost of many things is going to go up, but I guess our main cost, just when we break down our annual budget, is staff, far and away the most expensive thing, which we know is going to become more expensive. And actually, sort of estates costs, which a large proportion of that is energy costs. I guess just to acknowledge the energy cost and the price cap. Got a nice graph on screen. I'll just bring it up. Maybe Gandhi can help. Just an interesting article in BBC. Yeah, from the BBC website, just highlighting the graph, really, just the increase in the fuel caps. It was interesting just researching that leading up to this episode. So this is the jump that we're going to see here. So almost a doubling from 2,000 to about 3,500. Things could get a lot worse in January when the price cap could increase to 5,400 or something in that region. So that's really difficult. They've got an interesting graph actually just showing where when people pay their energy bill, where that money goes, which was interesting. And I thought the supplier's profit would be bigger actually, but there's a lot of unavoidable costs there. So that was interesting. Interesting thing is the price cap doesn't apply to businesses. So the households are relatively protected. It's a cap, so they're being protected from the full cost of energy increases, but suppliers can pass on the full cost to businesses. So that's going to be challenging for people. I guess the final point I was going to make, Gandhi, was there's been a lot of pressure on public finances from COVID. There's going to be increased pressure on public finances as we deal with the cost of living crisis and find ways to support, as a country, those people who are going to suffer most from increasing energy and other costs. And that means there's less money for the government to spend on things they might have or otherwise planned to, like strengthening public services and strengthening the health service, which does need strengthening and does need increased investment. So that's not going to be forthcoming, which I think is just a bigger challenge for general practice in general. And we do suffer from underfunding in other parts of the health service and social care as well, because when patients are frustrated that they're waiting a long time for their outpatient appointment, they will come to the GP because we are accessible and ask us to chase that and engage us in supporting them with that. And similarly with a lot of social issues, we're actually, whilst people complain that accessibility of general practice has gone down, people still often find us the most accessible part of the system to come and try and get some progress on issues. So we will suffer from the wider defunding of public services.
Yeah, interesting. I did a little bit of audit of the contacts I had in the past couple of weeks. At 30% of my consultations are purely down to patients waiting to be seen within other parts of the system. And that has a key implication in terms of that personal journey for those patients, but obviously in terms of workload for the practice and the challenge that it faces on the wider system, So those are costs that are coming up because of that.
Gandhi,
The other one,
shocking. 30% of your
30%.
of your appointments were because of pressures elsewhere in the system and not due to a need for general practice services per se. Absolutely shocking. I just thought I'd just repeat that because that's insane.
Yeah.
So it looks like we've got some comments. Oh, God, I was going to bring in some comments, but go on, you react to that.
So first of all, Christina was asking if we've fallen out again because we've gone virtual rather than on the sofa and stuff. No, not at all. It was just logistics. We kind of found last time we did this that whilst it was great, me and Andy being in the same room, a couple of things we weren't as happy with, so audio quality and that kind of stuff, and we probably just need to do a little bit more work to make that better when we're back in the room together. So no, we have not fallen out. Bridget is mentioning, as you say, patients are going to want to even more for free from us, and that will impact further workload and morale. Yeah. Do I blame patients? No. They are some of them are going to be literally below the breadline in terms of when balancing things. So can you blame them? To be honest, but obviously this is an issue that's going to drive increased workload, massively damage morale in general practice, reverse a lot of the self-care work that many places have been trying to do for the past few years. And it's going to have a damaging impact, I think, on the way that patients approach the healthcare system, to be honest. Christina's got quite a few comments in there. So energy prices are the biggest concern, fixed until the 4th of April 23. But then some colleagues are seeing it increase to 300%. Yeah, crazily high. And what energy saving measures they can put in place, which we're going to come to.
Yeah, but Christina's already done some things about it, which sound really sensible.
Yeah,
just to improve so LED lighting, change boilers, and so forth, making a big difference, which is good to hear. Essentially, yeah. Shall we start talking about some solutions, Gandhi, or do you want to do a few more of the comments?
Well, I think a couple of other things worth looking at is the other thing we talked about with energy, which we haven't talked about. Obviously, a lot of the healthcare services visit patients in their homes. And one thing that hasn't been addressed is the cost of petrol prices and the impact that's had on visiting services. So, as we all know, petrol prices went stupidly high, almost £2 a litre. It's come down a little bit since then, but it's probably going to keep going up as inflation goes up and things. But actually, how that's costed for some people in terms of their work, those are hidden costs that we don't see. And actually, the reimbursement, so HMRC have not changed their tax reimbursement for mileage at all in the past few years. So it's still 40p a litre is all you get reimbursed for having to.
It's still the same as when I was locoming about 10, 15 years ago. Yeah, still the same.
So this is an area where the government is making it potentially a significant. I'm not going to say profit. Profit's the wrong word. Surplus, shall we say? because it's not in line with inflation. It's not in line with the cost of living in terms of what people are having to do to travel to work. And I think that's going to have more of an impact than we people think. So people saying that, well, I can't come out because of the travel costs and stuff. They're going to ask for more visits, and visits are massively time intensive.
Yeah.
So that's going to be a huge issue in terms of driving additional challenges.
Yeah. Oh, Gandhi, I was going
Yeah.
to say the phenomenon you're describing is called fiscal drift. So this is where the government, they leave thresholds at the same place while inflation takes effect, and basically the government collects the inflation difference, so the tax revenues go up.
Mhm.
That's the phenomenon of fiscal drift that you're describing. Although in some ways, actually, an increased tax take, so if that's used to pay for public services, may
Yep.
not be a bad thing. A lot of people
And
would
the reason why I
advocate
wanted to mention
that
that one is the
pay for
cost of
services.
provider services going up. So this is the
Yeah,
other part I think many people are going to struggle to initially understand, but it's an impact that's going to happen, and it's already happened, to be honest. So as we talked about, costs are going to go up. So those services where they can put up their prices are going to do so because they need more income. Yeah. So an example I can give you in Nottingham, there were contracts for phlebotomy services for practices that don't provide phlebotomy themselves directly. The local provider turned around and said that they couldn't provide that service within the cost envelope that was being asked for. So they asked for more money, and the system said, no, we're not going to pay you anymore because we don't have enough more money to pay you. So the costs of those things have gone up. That has then left a lack of service provision for certain areas. So, in my practice, there was a genuine shift in terms of how provision of a constant service like phlebotomy happened. And that's going to have, I think that's going to be an increased thing. So many providers who provide a service that is costed within various things are going to turn around and say, actually, we need to put up our prices because we need to pay our staff and do the work and everything else. Cost envelopes aren't going to go up.
mm,
ICBs and that kind of stuff are going to say, well, we don't have the money, or they're not going to renegotiate the contracts is the bigger thing. So therefore, people are going to pull out, and
yeah,
there's going to be less services available. So I'm afraid people may have to understand that various other services that are available are not going to be available on the NHS anymore.
yeah. It's pricing power. That's what you're describing here.
See, Andy knows the proper terms. I know the
So
principles. He knows the
yeah,
terms.
in a refreshment inflation environment, companies that you might want to invest in that might do quite well are those that can control their costs effectively by
Mhm.
bargaining with their suppliers and so forth, like your big supermarkets or whatnot, and those that can pass on costs to customers who have pricing power, and that actually can reduce unwanted demand and increases the
Mhm.
profitability of the individual kind of delivery of service or encounters that you have. But general practice really has neither of those because we're all quite small. So we don't have much pricing power. We don't have much bargaining power. And we certainly don't have pricing power because the government buys on bulk just about everything. They commission just about everything we do from us. So we've got neither. So it's
Mhm.
going to be tricky. So, but shall we provide some solutions, Gandhi?
We will try. So we are going to now try to. Yeah, everyone's probably thinking about that. What is the options that we've got? But we do have some solutions, and I think it's important that we recognise that some of these do not apply to everywhere, and also the level to what you can go into some of these solutions will absolutely vary across the board. What I would ask for many of our viewers, if you can add in here, this would be awesome for us, because we're pretty sure we haven't got everything right. But one that absolutely needs to happen, I think, is communication with staff. Do you want to talk about this one, Andy?
Yes, I mean we recently sent our staff a letter because we modified the pay rises that we'd done this year, and some people needed some additional backdated pay rises to April because of the recent pledges that the government has made around pay rises, and we used that as an opportunity to, whilst we were communicating something that would hopefully be seen as relatively positive to many members of staff, that they were getting another pay increase, not in line with inflation, but they were getting a pay increase. We took the opportunity to remind them about how general practice is funded, that if there is a difference between the funding we're receiving and what we're paying out for staff, that it's the partners that are picking up the difference. So there's a reduction in partner income, and then that's partly how we are buffering these changes at the moment. So just reminding them of that now while we're giving them some relatively good news, just to prepare them for what might be a difficult
Mhm.
6, 12, 18, 24 months when we may not be able to deliver the increases that they would like. And actually, that went down quite well. And we had some conversations with some individuals who didn't realize quite how it worked. And it seemed to go down quite well. I think you've got to be really careful to get the tone of these communications right and have the sort of culture where you're perhaps already quite open so people can have a conversation with you about it if they don't fully understand. But for us, that felt helpful. I think the communication also runs to patients as well. There's an opportunity to have conversation in PPGs or put information on patient websites or out through social media challenges. Again, I think the tone is really difficult, but at least the cost of living crisis is an issue that is writ large in society. So it's something that you can point to, that can connect to when you're talking about the difficulties for the organization. Have you had any experience trying to communicate these concepts with either staff or patients, Gandhi?
So we're about to start that process because we're probably a little bit behind in terms of doing that because, yeah, basically me and my partner have just both been so swamped under, to be honest. And it's something we've come to a little bit late, but it's definitely something I'm going to be tackling the next couple of weeks. I think, keeping morale up is going to be a really challenging thing over the next few months, and particularly the next 8 months. And I think that's really something we need to focus on. Partly as well, because one of the things that people forget about is when staff leave, that leaves obviously a gulf in terms of the workforce that you've got. Training new staff takes time. So in terms of getting back up to scratch, even if you had the resources to do that, is not something that's going to happen quickly. So that has a bigger impact on the remaining staff. That makes the problem even worse. So then you can get caught into this cycle of things just getting worse and worse and worse because of those challenges. And that's one of the things we need to be cautious of trying to prevent, because actually, paying more for staff, whilst we would love to do that straight away, it's a challenge. But if you don't have the ability to keep your staff, you're going to end up in a cycle that will probably damage you even more. And we are seeing that already.
It's tough. I'm not sure that's sounding like a solution. But,
Wait, okay. So what is the solution? Is to be open and honest. Here's the
Yeah.
first thing: is to be transparent about the finances of the business. Because actually, if you're not, and people have this view that some people are just hoarding everything, and we know that some parts of the media love to vilify general practice and say that GPs earn X amount of money because they're just sitting around doing nothing. Absolutely not true. But that's where certain parts of the Daily Fail and the Tory Graph and stuff are always loving to direct stuff. Often, cynical view with a view to trying to defund general practice even more and stuff. But the reality is that that's not the case. Many people are working above and beyond to try and keep things going for the benefit of their practices and their patients. And the reality is that communication is the best way of making that clear to people. And I would hope that that would be a good start. It's not going to be the only solution, but it's a good start.
It's a good start. Another area where we're trying to do better at my practice is really getting ahead of this issue of that increased need for patients for support with things that are directly related to the cost of living crisis. So support with particularly stress originating from financial issues, issues around being able to afford enough food, eat the home and so forth. We are not the best place to deal directly with those problems that patients are experiencing. So we're beginning to think about how we signpost, make sure we know what services are available in our area and how we signpost and connect people with those services rather than potentially a GP appointment, that they are redirected to the better place to deal with their issues. I think social prescribers, some of the primary care network staff could be really, really effective at going a little bit deeper, perhaps, than you can go in a receptionist conversation where they need to get the phone down and pick it up so that the next person can request their GP appointment. I think they're going to be really, really helpful. So useful destinations are sources of financial advice, Citizens Advice Bureau, financial charities, housing charities, certainly food banks. There'll be all sorts of other explanations, and even actually the self-referral counselling services, the IAB services that are out there, I think are going to be appropriate for a lot of people, as well as just having a general refresh on signposting to your first contact physios and your other, making sure people land with the right people for their problem, but particularly for those social issues. That's what we're thinking about, and getting out ahead of that problem before it hits us.
And it seems that NHS England have tried in some ways to support that. So there is an increased funding for, I believe, an extra 1,000 social link prescribing workers across the country that was announced a couple of weeks ago. The challenge with that, again, onboarding time, availability of workforce, various aspects. But you're right. I think the social link workers are a key resource that we will need to be directing to. and using some of those innovations that we've talked about in our previous episode about the ARS roles, such as the financial social link workers in particular. So those with a focus on financial challenging matters, I think they're going to see a significant increase in workload and need to support our patients with the challenges that are coming forward.
Yeah, PCN's working with organizations that have expertise to deliver this advice to bring people
Mm.
online using social prescribing. ARS funding, I think, is a real good innovation, and not just in the area of financial advice, but probably other
Mm-hmm.
specialist advice as well. It's always been a problem that social prescribers, there's lots of them, and they can direct people to different sources of advice, but there wasn't really any funding to increase the destinations and the actual service to provide that advice and those interventions. So using that funding creatively, I think is a really, really good idea. Any other solutions? We've got quite a few in our Google Doc here.
Yeah, so I think looking. You mentioned about the streamline and the workflows and stuff for that kind of thing, and maybe this is the opportunity to take a look at your workflows within the practice, because some of these challenges are going to come. Do you look at your answer phone message that starts at the practice to help direct patients before they've even got to the right, the reception team? Because actually, do they just need to go direct to these other organisations and stuff rather than to the practice, for example? Online, using your websites to help direct people to the right services and stuff at the outset and things. I think
Mm.
other kind of things though are important to be aware of. So switching off the stuff you don't need and actually really consider what do you need on all the time. I think it's going to be a lot less than people realize, and actually that's going to have a huge potential savings for many places. The question is, to what level do you go? That's the important part.
It's tricky, isn't it? Christina was saying she's already explored LED lighting,
Yeah.
which is fantastic. Anything that heats water always uses a lot of energy, or that heats air. So
Mm.
look at heating levels, thermostat levels, um, the thing that keeps your water boiled for your cup of tea. I'm sure every little helps. It's a shame that we have to look at
Yeah.
these things, but I think
So actually, are we moving
to
to a point where some practices will probably have water geysers? The pull down ones where you get automatic hot water from. Actually, is it time to switch those off and just use a kettle
mm,
and boil it when you need it, kind of thing? Have a really, as best as you can, energy efficient kettle and just use that in place of it. Yes, it means you may have to wait an extra minute or so for your cup of tea or coffee, but if you're saving the fund and the cost from there, then actually is that more effective? Because the
mm.
cost of that geyser is probably just going to quadruple.
Yeah. In the danger of geeking out here, I had this conversation with my manager, and he actually assured me that the model of instant hot water geyser thing that we have is more efficient than a kettle, because of how it's constructed, and so it has an integrated thermos flask inside that holds the water at the right temperature and all sorts of
Hmm.
things. So do your do your research as well, to make sure that what you're doing will be effective and have the effects that
Hmm.
you want. I think, yeah, these are quite small ticket kind of items. So I would suggest just make sure that you understand the energy implications for your practice. So have a conversation with your energy supplier. Sometimes you're on a fixed term contract. You might come to an end of that, understanding what that step will look
Hmm.
like as you come off a fixed term contract and move on to the next one or into variable pricing. Have a conversation with your landlord as well about the energy price increases that they expect. You may be a few steps removed from your energy price increases, but you still need to understand the impact. For example, I think with ours, they anticipate the charge for the year, and charge you at that rate, and then they recalculate it the next year. And there's often a charge required to make up the difference. You may have underpaid for your energy for that year, and there may be a big
Hmm.
charge for retrospectively the energy that you have been using throughout the year, as well as an increase on the standard charge that you get charged monthly. So just
Yep.
have a look and have conversations and get ahead of these things and plan.
And I
Um,
think the other part as well, if you're in a shared premises, how much energy are you actually using versus other parts of the premises? Is that being allocated appropriately? Do you actually have direct billing? Because I know many places that don't. They just are given an amount they're apparently meant to be paying because that's what they've equated, or it's a percentage rather than actual equivalent use. And actually, if you're doing loads of efforts to try and reduce things, but other spaces within that estates aren't, is that fair? Is that appropriate? Is that the difference between you going under? Those are the conversations you need to start having with the estates agencies and stuff. So yeah,
Yeah,
definitely
absolutely.
opportunities for people to start those discussions early, and this goes back to that communication thing that we mentioned at the
Yeah.
start. Is your
Yeah.
starting point for a lot of
Don't bury your
businesses.
head in the sand, I guess, which
Yep.
I'm sure we won't do. But there's just so much other things to be concerned with when you're running a GP surgery that it's
Hmm.
possible to not have your eye on some of these issues. And other things we've talked a lot over the last few years about the adoption of digital technologies around streamlining access and
Hmm.
electronic consults and things like that. It may be time to look at those things. It might be that you can put cost of living advice into that electronic kind of flow that lands people in a certain place, with an
Hmm.
appointment or something else to direct those people away. So look, if you have digital technologies already implemented, look at how they're implemented and are they cost of living crisis appropriate, or think about putting them in place if you've not got them there already to improve your workflow. Um, Also, other processes within the practice. It's really interesting how practices are in different places around who does what and how much around processing incoming letters, prescription requests, and so forth. I speak to some practices, and they have very much gone in the direction of specially trained administrators reading and triaging letters, taking a lot of the actions from letters that don't need to be done by a clinician, or the prescribing around that is done by a pharmacist, that a lot of letters don't go to see a GP unless it's absolutely necessary, for example. So
Hmm.
look at processes around letters and prescription changes and other things and see if now's the time to become more streamlined around some of those things, and there might be some gains for some practices there,
Hmm.
I guess. Hmm.
Yep. And I think other things to consider are, it's a mantra that I've been hearing repeatedly from people like Martin Lewis, so of money saving expert. Heat the human, not the home. Um, Thinking about aspects of, so Andy mentioned about the cost of heating air is actually quite expensive, and increasingly it's going to become so. So actually, how do you heat the person rather than the home? Well, one thing you could consider, and it's interesting, is so Nat's mentioned it in the chat as well. Buying staff leases and going to enforce a fixed thermostat level. Um, Interesting comments, and I think that again, that communication is important with that. But actually, yeah, heat the person, not the home. So I'm going to be wearing big fluffy jumpers to work. To try and keep me warm and stuff. And gloves even potentially. Apart from when I'm examining patients, apart from obviously latex gloves. Then.
Wow. Wow. The times we live in, it's really strange, isn't it, that we're having these
Well,
conversations.
these are the steps that places are going to have to consider taking. This
Mm.
is the depth of the challenge that we need to look at. Other things. So look at boiler timings. So Christina's mentioned that. Actually be smart with the way that you heat your environment. Don't just have it on all the time. Look at the phasing so that you heat the building for the time that you need it. And actually, do you need a heating on until 6:30 if you're built if everyone's leaving at 6:30? Which I don't know any practice where they do, but actually, do you then switch it off at 6:30? So then you'll have a natural cool down time for the building itself. So is that lag time enough to help in terms of mitigate some of the costs and stuff? One thing I've heard lots of places exploring significantly right now is solar energy, so solar panels for their premises and stuff, because then you can generate obviously income from that, selling it back the energy back to the grid. Because actually, energy supplies are going to be a challenge. We know that they're already talking about potential risks of blackouts and that kind of stuff.
Mm.
But the cost differential of having solar now with the price increases actually means that most places will probably get their money back within a couple of years, compared to before. It's like 10, 12 years they were estimating it would take for you to earn your money back from having solar panels. It's the significant increases in the cost of energy will mean it will actually take only 2 or 3 years. And the reality is this is a problem that's gonna be with us for about 3 or 4 years, they're estimating. This is not, yes, we're talking about the next 6 months and next year being the big challenge, because that's the time of change. This whole thing is not gonna go away anytime soon, though. It's gonna be with us for several years. So, it's understanding those level of changes you need to potentially consider making and stuff.
Yeah, the fleece comments going down really well from Nat. Um,
Mhm.
Janet, Janet may be putting those in place, I guess,
Yeah.
wherever Janet works, which is really good. And it's a really great idea, actually. Um, and they can look quite smart as well. You can get your practice logo on there,
Yeah.
so it's
Other
good.
things to consider, non-car related transport, car sharing. Do you need to have that discussion with staff about actually can you coordinate, car sharing, cycling to
Mm.
work? scootering to work. We've seen the rise of electronic scooters, and potentially if there is a law change that allows that to happen across the entire country. So Nottingham's one of the test sites for having electric scooters and stuff. The energy for those is cheaper. And actually, if you're not that far away, the time differential probably won't be that much different compared to a car.
I've seen a few people fall off them though,
Yeah, be
just
careful.
from my own personal experience.
Mhm.
So make sure you practice as well. And just an important comment from Mohan as well. Just we talk about signposting to these other places,
Yeah.
but is the capacity there to receive them? And there may be innovative ways to use SPLW funding to support those organisations, even.
Mhm.
But I know we encourage our social prescribers to have a relationship with the places that they are sending people to, so that there's a little bit of a feedback loop or release valve, so that we can know if we're sending too many
Mhm.
people there and they are struggling. But absolutely true. And at a kind of strategic level, that's something that really needs to be looked at, and those organizations need to receive better funding.
I guess the last kind of tip I've got is just basically reevaluate all of your existing contracts. You know, are there elements of things that you don't need to continue considering, or just refinancing them? So, finance any of your debt that you've got. Printer costs, we're seeing less use of printed items, as many practices go to paper light or paper free completely. So can you reconsider those costs in terms of how you look at things? And just other provisions that you've got, your suppliers and things, look around, because actually everyone's going to be doing this. This is possibly a good opportunity to reevaluate a lot of those kind of costs that you may have.
Mm. And Gandhi, one of the advice for individuals is to take a look around and see what benefits or grants you might be available to you. There might be more than you think. So we'll be asking individuals to get advice and do that.
Hmm.
Chris earlier on had just asked, have either of us received any communication from ICB about any additional support for practices to cover costs? I mean, I know I haven't been aware of any.
No,
If that's something that the LMC might be raising or asking for, it's a very good idea. I do wonder if
it
there is
is,
any need
and I
for it.
think that this is one thing I would recommend that a lot of members of the BMA and members of the LMCs and stuff start asking within the system, what is the support that's going to be coming for general practice to help support our patients with the cost of living increase? Because I get the impression that general practice is being viewed as not the people that need to be supported. As usual, a lot of the support will probably be directed towards hospital environments. Hospitals have significant costs for this. Hospitals are generally warm spaces. They have to be to help patient health and stuff. Their costs are going to be stupidly high, to be honest, for energy and that kind of thing, and the implications that they have. And we are going to see, I guarantee you, we're going to see a reduction in service provision by many providers in secondary care. They'll just say we're not providing the service anymore because we can't. We've already seen that as it is. This is going to increase. So those challenges are going to push even more workload shift towards general practice. So actually, I think it's very appropriate for all of our colleagues, members out there, to be saying to the ICB, saying to the LMC, saying to the BMA, what's happening?
Mm.
Simple. Yeah. What's going to happen? Because this is a challenge that we are not going to see go away. I think that there's lots of opportunities possibly to explore, and one thing that we've got ready for you for next week. So if you are watching us now, or if you're watching this on replay, definitely check out next week's episode, because I had the opportunity to have the team from Medics Money basically talk about individual things that GPs, those in primary care, can do to significantly try and help save you money. So if you want that episode, jump in and join us next time. We've still got loads of comments coming through, but I'm afraid, Andy,
Yeah.
we're going to have to move, aren't we? Because we've kind of hit our time limit for this
Oh, Nat, I wonder
episode.
where Nat is. Oh, no extra funding. I read that initially as there was extra funding.
No.
Okay. I suspect we
So
all may be in
again,
a similar
this is the
boat.
message we are hearing from a lot of places, that the ICB is just turning around saying there's no extra money at all.
Yeah.
So that's going to be fun.
And someone expressing
Um,
concern about care homes as well,
Yep.
who need to keep their space warm for the health of their residents. They're going to struggle. Absolutely true.
Mm-hmm.
So I guess in conclusion, from my perspective, this has sounded quite bleak, but general practice has faced challenges before. We are resilient. We are adaptable. We benefit from having sort of quite direct control over a lot of these things, like where we get our energy supply from, and where we source other supplies and things from. So we've proven adaptable. Maybe I'm sounding a bit over optimistic, but I guess we'll come through this and there'll be another huge challenge around the corner that will consume our attention within
Yep.
a few months or next year. So I'm sure we'll get through it, but it doesn't mean it's difficult, and it will take its toll. But hopefully, some of the tips have been helpful.
Absolutely.
Final
I
words,
think
Gandhi?
yeah, as you mentioned, Andy, this may have been a bit of a doom and gloom episode to some people, and yeah, quite rightly so. It's a big challenge that's coming our way. Important, and the key thing I will put through, despite the doom and gloom, the first thing you need to do is not bury your head in the sand over this. You need to start talking to people, talk to your partners, talk to your practice, talk to your patients. These are things you have to do. Otherwise, it's going to be so much more painful for you, to the point where it may even mean practice is going to hand back their contracts. And I suspect we are going to see that, I'm afraid. We're already seeing it in some places. So, to mitigate this as much as yourself, we hope you've enjoyed this episode and found it of at least value. If you have, please leave a like or a comment, because we really appreciate those to help directors in terms of this kind of content. And absolutely share this with your colleagues so that they can start being aware of the challenges that exist and why they need to address them. And as always, EGP Learning, we're here to help tech enhance your primary care and learning. We will definitely catch you in the next episode. See you later.